Welcome, everybody. This is Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital. Thank you so much for joining us, where we are absolutely privileged to welcome Dr. Rocky Marotta and Dr. Mark Russ, presenting on the topic neuropsychiatric manifestations of COVID infections, clinical presentations, possible underlying pathophysiologies, and institutional responses. I will have the pleasure of introducing them in just a moment after a bit of housekeeping. Time has gone along quickly in 2023, and we've reached the half-year mark for our grand rounds. And today's lecture is the last one before we take a break through July and August. And we'll be back with our fall series starting September 13th with Dr. Matt State, the chair at UC San Francisco, speaking to us on traversing the difficult path from genes to treatments in autism spectrum disorders. We hope you can join us then. Invitations will come out in late August. Back to today, I'm pleased to be joined by my colleague, Dr. Andrew Gerber, who is the president and medical director at Silver Hill Hospital. Thank you, Andrew, for joining me today. And we both look forward to moderating a Q&A discussion with Dr. Marotta and Dr. Russ at the end of their lectures. That will be your opportunity to put forward questions and comments. So you can do that by submitting a question anytime during the lecture using the Q&A link, either with your name or anonymously if you prefer. A key component of our program is providing no-cost continuing education credits. If you wish to receive CME or CEU, please complete the evaluation survey that will show in your browser, and we'll email a copy of it as well to today's participants. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME-defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used or on patients. And it is now my great pleasure and honor to introduce our guest speakers today, Dr. Rocky Marotta and Dr. Mark Russ. And then I will turn to Dr. Gerber for some brief welcomes as well. First, Dr. Mark Russ received his BA in 1976 from Haverford College and his MD from Drexel in 1980 with academic distinction in mental health sciences. He completed his internship, residency, and chief residency in psychiatry at Montefiore Medical Center, Albert Einstein College of Medicine in 1984. Dr. Russ joined the faculty of New York Presbyterian Westchester Behavioral Health Center in 1984. And he directed a brief inpatient treatment residency training unit. He moved to the Zucker Hillside Hospital, North Shore, Long Island Jewish Health System in 1996, where he was the director of acute care psychiatry. He was the director of inpatient and emergency services for most of his 18-year tenure and associate professor of psychiatry at the Hofstra North Shore LIJ School of Medicine. In 2015, he returned to New York Presbyterian, where he was vice chair and medical director of New York Presbyterian Westchester Behavioral Health and professor of clinical psychiatry at Weill Cornell Medical College. In 2023, he assumed his current role with us as the chief medical officer at Silver Hill Hospital. His academic interests have included exploring the neurobiological underpinnings of self-injurious behavior in patients with borderline personality disorder, assessment of suicide risk, aggressive behavior in psychiatric inpatients, inpatient unit structure and function, and quality improvement in the COVID-19 crisis. He has authored and co-authored 45 peer-reviewed papers and has long been an adored teacher to medical residents and students throughout his career, and has received best teaching awards for that, including the American Psychiatric Association's annual Irma Bland Award for Excellence in Teaching Residents. Dr. Rocco Marotta currently serves as the director of the Center for the Treatment and Study of Neuropsychiatric Disorders at Silver Hill Hospital in Connecticut. And he is an assistant clinical professor at Yale University and a board certified in psychiatry and neurology and a licensed psychologist. Dr. Marotta graduated from Manhattan College, where he majored in psychology and Western civilization. After earning his PhD from City University of New York in psychology and neuroscience, he completed a 3-year NIH fellowship in biological psychology and psychiatry and a 1-year internship in neuropsychology at the Montefiore Medical Center and Albert Einstein College of Medicine. He earned his MD from Cornell University and completed his residency in psychiatry at Cornell Medicine's Payne Whitney Clinic. Dr. Marotta has served as chief of acute inpatient psychiatry at St. Luke's Roosevelt Hospital in New York City and chief of the inpatient psychiatry at Danbury Hospital in Connecticut, and has as chief of the medical psychiatric services at the New York Medical College at Westchester Medical Center in Valhalla, New York. In his clinical practice, he focuses on the treatment of severe psychiatric illness such as bipolar disorder and schizophrenia, as well as on patients with brain damage who exhibit behavioral disturbances. In addition, he currently collaborates with General Steve Xenakis to build an intervention program for treating stress reactions for individuals recovering from COVID-19. His particular research interests involve the development of new pharmacologic interventions to improve the outcome for patients with treatment-resistant schizophrenia. Most recently, his focus has been on the potential of oxytocin as an augmentation to clozapine. Additional research has focused on developing treatments for patients with brain damage and on the psychiatric presentation of patients with HIV disease and on the neurosubstrate of aggressive behavior. I'm going to pass it to Dr. Gerber to make some brief remarks and welcome us as well. Andrew, to you.
Thanks so much, Jeff. And I'll be brief because I want to get right away to Rocky and Mark's talks. But I didn't want to let this opportunity go by without saying a couple things. One is just what an enormous privilege it is for me as the medical director here to be able to work with colleagues like Rocky and Mark. And in many ways, they're bookends of an amazing staff we have of 20 psychiatrists now. Rocky's one of our most veteran psychiatrists here at the hospital, built his wonderful program that you'll hear about and has been running it ever since. And Mark, who's been here only a little more than 3 weeks, but already is integrating so beautifully with the hospital's mission. But the other thing I wanted to say is I think one of the phenomena over the last several decades in organized psychiatry that I think we're all aware of has been a move for a lot of the academic departments to really specialize in neurobiological research. And while that's incredibly important and welcome, it hasn't always left room for this kind of scholarship for direct clinical practice. But the other movement has been, and for understandable financial reasons, a lot of the very expert clinicians in the field to move to outpatient work with private practice. And again, that leaves a gap in the kind of treatments that we do here at Silver Hill, that is with individuals who need inpatient or at least residential levels of care. So to me, Rocky and Mark really exemplify what I think we need more of in the field, which is seasoned scholars and experts who are devoted to the clinical care of individuals with serious mental illness. So with that, I will turn it back to you, Jeff, and really looking forward to the talk today.
Thanks, Andrew, so much. And Rocky, I'm going to turn it over to you to get us going here.
Okay. Am I on?
You're on.
Okay. I'm going to talk very fast because we have a lot to cover. And so our talk is about, COVID and neuropsychiatry and what to do about it. And I have nothing to disclose. We're not getting anything out of this, and our objectives are pretty straightforward: to talk about what we see and what we think can be done about the epidemic as it affects psychiatry and the country and families. I'm going to talk about myself, just my self-disclosure. I had a pretty bad case of COVID. I was sick for a couple of months, so that's the context. But, getting a viral infection in an epidemic and being involved in epidemics is actually something that's defined my life, my whole life, and maybe to be honest about it, before I even came into existence. I was born during the period of the polio epidemics, just before the vaccine, and of the strep epidemics, and in the Bronx and in Brooklyn. As a child, I remember people, meaning kids, other kids on the block disappearing and sometimes not coming back, and terrible stories about suffering in families. I also grew up with boys and girls who were paraplegic from polio. And I had friends my whole life who, were on crutches and who died young of heart disease from the strep epidemic. I mean, later on in my life, I went on, as you heard, to work on COVID with some of my closest friends. But my life has been bracketed by epidemics in other ways. just before the Second World War, my father, who was one of 9 brothers, and one of his brothers was about to be drafted. Ultimately, 5 of them were. But my father and my uncle Luciano came down with tuberculosis, landed up in a hospital in the East River. My father was very, very ill, and so was my uncle, and my uncle died before I was born. Okay, my father then spent several years recovering and didn't enter the service. Ultimately, 5 of my uncles were on active duty in combat units. The joke among my uncles to my father was that he was the lucky one because he got ill and spent the war in the hospital. But it changed the way in which my father, related to me and watching over me and everyone around him because of that. But it's even stranger. His father, my grandfather, was drafted early in the First World War and spent the war either in training or in the trenches, where the great epidemic of 1918, 1919, the great influenza epidemic, was raging and killed tens of millions, and under some estimates, 100 million people in the world. He seemed to always, paradoxically, the trenches of the First World War were relatively safe from that illness. He came home, never got sick. My grandmother was well, and my father was conceived, supposedly, according to family history, on the night of his return from France. One of my aunts died of that epidemic, again, long before I was born or my mother was born. So my family, both my maternal and paternal family, were affected by a epidemic in that fashion. That epidemic took relatively young people, people between the ages of 18 and 30. It was very, very different than what we're just going through with COVID, but also very young children. What I went through as a child, not fully aware, often took, again, young people. The epidemic in COVID was very different from AIDS. I went to college and was friends with a number of people who died of AIDS. And I and my closest friends went into treating AIDS patients. One of my uncles, the youngest of my father's brothers, died of AIDS. And my dear friend Alberto Acosta and I at Cornell took care of the special studies group, and we had a clinic of 40 AIDS patients, young boys, mostly young men, 37 of whom died under our care ultimately. So the effect of epidemics has sort of bracketed my whole existence. And so it's not strange that here I am now dealing with COVID. I was raised in a world where people, there were always messages and meanings in life. Before the epidemic actually broke out formally, Drs. Morens and Tabenberger published this paper in JAMA on the cataclysmic effect of the epidemic of 1918, which always interested me because of Grandpa's stories. This paper comes out before COVID, and it discusses what would happen if another great epidemic occurs. And the history of epidemics occurring roughly every 100 years, would we be ready for it? Well, it happens, it breaks out a few weeks later. In another uncanny precursor to what actually turns out is this paper by Bakinska and others, from Great Britain, what the effect of the great 1819 epidemic was on schizophrenia and psychosis and other neuropsychiatric disorders. Again, these papers come out before the present epidemic hits. It's to me a fascinating thing. COVID is a virus. It's a coronavirus. Coronaviruses are ubiquitous. The causes the common cold. I'm not going to go into detail about this, but we thought easy readings that we have on a list at the end of the talk, so you can link to them. It's highly transmissible, pathogenic, usually not bad, but it always can attack multiple organ systems. It's usually respiratory. It can be spread through the body, usually the vascular system, but this current one may also enter the nervous system through reverse exoplasmic flow. It means it can go up nerve roots into other neural structures. This has turned into a kind of nightmare virus. The particulars about the origins are being argued on the internet and other places at this point. But I just want to bring up something, which is this thing called the angiotensin converting enzyme 2 receptor. This receptors, again, on many tissues, in the lungs, obviously, but also brain, kidneys, heart tissues, and blood vessels. This is the receptors involved in the modulation of blood pressure control, but the virus enters cells using this receptor. So what are the kinds of impacts this epidemic has had in psychiatry? Well, from the view of the biological, psychological, social model we were raised to deal with, a major epidemic causes general anxiety and fear in people. This epidemic disrupted whole social systems and economic systems. So psychiatry had to deal with that as a general issue. But also patients with anxiety would become more anxious. Depression may have become more prevalent. The response to the epidemic has caused social isolation, interfered with ongoing treatment in many ways, both in general medicine and psychiatry. There was a real disruption, which Mark will go on to talk about, of the psychiatric system, over time. And in the general hospital, psychiatrists were called on to see marked behavioral disturbances. Often these were due to the general illness itself, because the virus interfered with respiration, oxygenation, and other physiological processes. But what does the virus do? Well, it has a predilection for certain tissues, right, inside the body. And again, it's this receptor on the lungs, kidneys, heart, brain, and blood vessels. The virus may interfere with general metabolism by affecting mitochondria, which is really fascinating in terms of long-term effects. It damages blood vessels, directly at times, causing leakage and inflammation, and allows the virus then to enter tissues it might not normally. It interferes with coagulation, which can lead to strokes. Strokes can lead to seizure disorders, etc. So very complicated issues of damaging many tissues of the body because of interfering with coagulation. And it also has marked impacts on the immune system and the way in which the body protects itself from other infections. This is just for those of us to say, in the hospital, meaning in the general hospital, lots of patients with COVID infection were in delirium, which is the same thing we found, Bill Breitbart and others and myself found during the AIDS epidemic. Lots of confusional states, lots of worsening states of anxiety. And the patients who were most susceptible to this would be older patients, often men would be more susceptible, people who were exposed to drugs and alcohol, people with other illnesses would show these states. But I want to go just a little bit beyond this and go past it. Well, what happens after you've recovered from COVID? Or you just had a minor infection or a minor, what looks like a flu. Are there other effects in addition to the effects that are acute effects that might actually kill you that persist? Well, that has become more and more clear that such things exist. They're given the name of post-acute sequelae of severe adult respiratory syndrome, co-virus, coenzyme or COVID virus 2 infections, or so post-COVID conditions or long COVID. I think it's easier just to say long COVID. These have long-term effects on the society as a whole if they influence large groups of people, interpersonal effects, psychiatric effects, right? And you have to say, well, who's going to develop this? I mean, if hundreds of millions of people have been infected with the virus and if several million have died, who will actually have long-term effects that would not necessarily mean that they had a massive stroke? Well, patients who probably had a more severe infection. So the longer you had a measurable infection might make you more vulnerable to presenting with a long case, okay? what would happen to these patients who might be admitted to hospital more often? They would show more admissions for other problems. They're more likely to show background depression, anxiety, and fatigue if they develop some prolonged syndrome. There's been now several papers out, and we have links to these and copies if you want this from us about what is now coming out just again in the last months about post-COVID sequelae. If what the individual patients will complain about is something called post-exertional malaise, okay? That is, that after they do things, they just feel terrible. And that's in addition to just being fatigued. That's a kind of critical distinction. And this is the kind of thing that will make you more and more withdrawn, more and more incapable of functioning. They describe brain fog. What's brain fog? Difficulty remembering things, difficulty recalling certain words, not being able to attend for long periods of time, not being able to function the way you normally would. They complain of being dizzy, they have GI symptoms, palpitations and discomfort in the chest, decrease in sexual desire or sexual capacity, changes in taste and smell and thirst, which is very common in COVID, acute infections, also chronic cough, which we're seeing a great deal now. A lot of people who had COVID as a regular infection who felt really ill about chronic cough, chest pains, and abnormal movements. Now, these are the same kinds of things which were described after the 1919 epidemic, also described after actually cancer patients getting chemotherapy. And the next slide is, and something we see all the time now, which is, myalgicencephalomyelitis, which is chronic fatigue. It has exactly the same kinds of symptoms and symptom clusters of fatigue, cognitive dysfunction, sleep problems, autonomic dysfunction, palpitations, GI disturbances, and again, this interesting post-exertional malaise. And again, these, chronic fatigue syndromes, myalgic encephalomyelitis, seem to be due to viral infections inducing inflammation and immune reactions, which is the same kind of sequence of events that we think are occurring with COVID and are inferred to have occurred with many viral syndromes, including in the Great Epidemic. Long COVID not only occurs in adults, but seems to also be presenting with children and adults. There's papers coming out now. We have a link to Zhang's paper showing they had 40 studies. They looked at 12,000 plus patients, and they said that roughly 23%, close to a quarter of children who had COVID infections ultimately showed long-term effects that were present still a year after, and they could look like problems with learning and anxiety and relatedness. And again, these are complicated because you, again, have to look just beyond if the consequence of the virus or the effect on the immune system, but what has been going on in society with disruption of the school systems, children playing with others. My grandchildren for a whole year never played with other children. It was a pretty terrible kind of situation growing up. Just to say that children who already had some problems like depression or social problems were more likely to show those long-term problems. What makes you more likely to show a long-term reaction to COVID? Well, if you had a long infection, if you had a severe infection or you were infected for an extended period of time, if you were prone to prolonged hyperinflammatory states, that can happen to some people. They're born with those kinds of vulnerabilities. If you actually did have coagulation difficulties that might have led to microvascular disruption, if you had cardiovascular disease as a consequence of the infection, Dr. Weiner and Dr. Shishala and I think we've seen cases like that. When we look at our own patients admitted to us who are not responding in we think would be an expected way to medications or seem more ill than others, and we check their immune markers and their antibodies to COVID, we often find people with very high markers, very high, antibodies against COVID. And then if you had a pre-existing neuropsychiatric illness, since the neuropsychiatric illnesses overlap with the signs and symptoms of the long COVID or with the chronic fatigue, you're more likely to see an exacerbation of those in certain patients, right? And this will be an overlap in this, right? Are there long-lasting cognitive abnormalities? Well, there's a difference between a complaint and a measured disruption. And so Ferrucci, this name appears in a great deal of the literature. This is the group out of Milan. The Italian research groups, they had a terrible time with COVID very early on, very high death rates. And so they've been studying this since the very beginning, but this paper showed that even months after discharge from hospital, COVID-19 patients had cognitive abnormalities, they easily fatigued, difficulty concentrating, memory deficits, and cognitive speed was really down. And on standardized neuropsychological batteries, they saw these, so it just wasn't a complaint. It was the demonstrable signs and symptoms of the illness. And so this seems to be a part of this, part of what's really going on. So I did that. Okay, so, well, can we find things that will, correspond to, correlate with this in the physiology of these patients? So the question is, can you see things in MRI, SPECT scans, PET scans, other things? Are there changes over time, right? And do these changes over time in any way correspond to, correlate with the presentation of cognitive changes or specific presentations of psychiatric disorders? Is there any sense of the way in which cases are coming up? Are their presentations different? Do they respond differently to medications? Is there a change in course? And again, there are papers now appearing where others are reporting what I think we are beginning to see, which is maybe more motor disorders, maybe more side effects, and maybe difficulty in clearing illness. So it's taking longer for patients to get through. And so and you'll often see, even in the popular press, references to the British MRI study. So because of when you have national health systems and people have data on all patients the way they have in Great Britain, Scandinavia, and some of the other European countries, you sometimes can extract data groups that are very hard to run as regular studies. So they had all the people who had MRIs of the brain before the epidemic hit, and then they found they had 401 patients who then, within 3 to 5 months later, had another MRI for some reason, and they were able to compare the MRIs of patients who had COVID to patients who did not have COVID, and even do psych testing on them, and show that in the patients who had a COVID infection, there was a reduction in the thickness of the gray matter of the cortex. They also saw changes around the orbital frontal cortex and perihippocampus. Those are critical areas for attention, memory, sustained thought, abstract thought, and also the hippocampus is the area that's critical for memory, and it's one of the few parts in the mammalian brain where cells constantly regenerate, and those regenerating cells are critical cells. They also found markers of tissue damage in various regions of the brain, primarily in the olfactory cortex, which makes sense since it's a respiratory virus that also can move up along cranial nerve roots, that it would go there. They saw a greater reduction in global brain size and measured cognitive decline. So this is a marker that the virus has an effect on the brain that can be measured even in patients who might not have been severely ill. Are there other markers that we now know about? Well, only in the last few weeks, there's been several papers addressing this issue. So both in the New England Journal and in the Journal of the American Medical Association. One used a technique which is called TSPO, and I don't want to get into it, but with the exact technique, but the technique allowed them to look at whether or not there were markers of inflammation in the brain of patients who had COVID that was still present months after the illness, and also to do psych testing on them. So the psych testing showed slower motor speed, low energy, low motivation, high hedonia, sounds like depression, sounds like chronic fatigue or the long COVID, but they also found distributions of inflammation. And the inflammation was in the areas, what they call the ventral or the lower areas of the striatum and putamen. Those are areas really of the limbic tissue involved, connecting about emotion and activation, and in the dorsal striatum, which is about motor control and feedbacks between the frontal lobe. These are also the areas that receive the ascending fibers from the lower parts of the brain, like the dopamine, noradrenaline, serotonin, that are involved in, we think, in depression, psychosis, memory, intelligence, etc. So that's one. I got to go back. And that's one of the papers. And the other paper that shows that same kind of thing is, again, by the groups from Milan, by Ferrucci and the others, where they used PET scans to show areas of damage. And again, there was abnormalities in brain metabolism, and also possible amyloid deposits that persisted for a year after infection. Those are the kinds of things you would see in the brain if there was dysfunction that might lead to cognitive difficulties. And again, it's in places like hippocampus and the striatum that are heavily involved with, memory and energy. Going back to that thing I mentioned to you about the angiotensin receptor. So the angiotensin receptor would be a receptor whereby either the virus itself or possibly an antibody against the virus, which is called a mirror antibody, might damage your cell. So the distribution of the angiotensin receptors becomes critical. So they're on the lining of blood vessels because they're involved in blood pressure control. But they're actually found in the brain, and they're found in places in very high levels in the limbic system, but also in the brainstem in other areas like the substantia nigra, the ventral tegmentum, again, and in the tracts that produce the fiber bundles that go up into the higher parts of the brain that sustain activity with dopamine, serotonin, and noradrenaline. And those are our theories about, psychosis and depression involve those areas. And those are the same areas that by inference were damaged by the great epidemic of 1918, 1919. So, and the damage to them doesn't mean they're destroyed, but it may mean that they have lost functional reserve, which will make them more vulnerable over time to beginning to fail. So, in other words, you don't show a disorder a year later. It may not be till 20 years when you cross a certain threshold. So things like this, again, set off alarm bells and make us think, what are we going to do about this if this is really an underlying process? So that certain people, because of their genetics or because of the particulars of their getting the infection, may be more vulnerable. I'm going to keep going faster. These are, I just referring to the fact that there are networks in the brain, which are called default networks, that are absolutely critical to memory and cognition. I'm not going to, so I can finish everything, I'm not going to go into this in detail, but they all overlap with other important issues. This is a slide from the paper on what the 1918-19 epidemic did that led to an increased incidence and intensity of psychosis in the years after the epidemic. And we could take this roughly the same schema, that there could be something because the mother got the infection, or the child or an adult got an infection, in a way it would cause a disruption of many different areas of the body and the brain, which would lead to inflammation, even chronic inflammation and damage to certain parts of the brain that was central to the control of emotional responses and cognition, which would be central to developing schizophrenic spectrum disorders, because they would disrupt dopamine, it would disrupt other critical neurobiological systems, all right, that are right about what our theories would be, but also in terms of what we now know, disrupt the hippocampus in terms of regeneration. But you could, instead of psychosis being in that circle, you could put depression, or you could put bipolar, or you might even put cognition in general. That is something that could occur in all these states. So I've outlined to you sort of a very bad story about how this virus is not something we may escape from very easily, that even with various interactions of the state to cut off the virus, to with the use of vaccines, that it might still have an effect because it has affected so many millions of people. So what could we do moving forward in terms of what we know? Well, since a major factor in how the virus will cause long-term disruption would involve inflammation, anti-inflammatory drugs might be useful, and we use them all the time. Aspirin, Motrin, or you can use steroids, immunomodulation, even antibiotics. I mean, there's been theories about schizophrenia, speak about something I study all the time, that say that there are people who respond to antibiotic treatment of psychotic states. And there are people who are being given various drugs to decrease, inflammation, and that might help. So that might be something we do moving forward, which is to use anti-inflammatory drugs. There's one interesting paper using metformin. Now, metformin is used to treat, I have this on this list, metformin is used to treat, of course, type 2 diabetes and help people lose weight. Well, there's a study with COVID giving metformin to patients when they got the COVID infection and continuing it. And patients on metformin, they were obese patients, they were a special group, given metformin had lower rates of long COVID. So metformin, which also is an immunosuppressant and anti-inflammatory drug, can do that. There's a study of fluvoxamine, which is an antidepressant, where the data isn't so clear. But there are other things that are possible. I mean, oxytocin blocks the angiotensin receptor. Oxytocin is an immunomodulator, and it's an anti-inflammatory drug. And oxytocin and clozapine, to go back to what my research is on, both protect the cells of the hippocampus, the constantly regenerating cells, from being damaged, and they facilitate the turnover of those cells. So it's kind of interesting. Not that I would treat COVID with, clozapine or anything like that, but there must be other things out there that make this interesting. One of the things that COVID does is it increases the production of a protein called CCL11. CCL11 is a protein that increases as you age, and you have trouble with cognition. But the COVID virus actually increases that. So medications that might interfere with that production might also be very, very useful. 2 minutes. But anything like this might not work. This is what you take a single dose of oxytocin. These are 20 odd proteins that change within minutes. How do you know what anything might do that's positive or negative? I just putting into any kind of inference like this is very, very hard to know from a purely scientific basis. It'll take large group studies to tease this out as an intervention. So this is my speculation. What might happen? We might expect over the next decades, because of the epidemic, complex presentations of cases of depression, mood instability, and psychosis with more cognitive disruption and more physical complaints, which will make treatment more difficult. I think that substance users and alcoholics or people who've suffered some other kind of central nervous system damage will also present as being more along in or more dangerous to themselves in some fashion or more ill because of having had the virus. I think we're going to get increased incidence of psychosis and treatment resistance. I think Howard and Sumer and I and others are already seeing that in reports appearing in the literature. I think it's very likely because of the areas the virus may impact that there'll be increased incidence of movement disorder side effects, what we call extrapyramidal side effects. And I actually saw patients have some strange effects, some of the patients on clozapine unexpectedly in the last months. I've even seen somebody who 4 years on clozapine never had a problem, all of a sudden have her blood counts drop when she got COVID. So such cases I think will appear. I think there may be earlier onset of chronic movement disorders like Parkinson's disease, which is what happened in the great epidemic of 1819s. And again, increased incidence of side effects to medications, as well as cognitive impairments, ADD kinds of symptoms, disinhibition kinds of symptoms, and all kinds of things that are not known. My dear colleague, friend, Michael Raicano, who I speak to all the time about the epidemic, his feeling is it's going to be unmasking of vulnerabilities, much more so than induction of new disorders. I think there's going to be psychophysiological interactions, but I also think there are many things going on because of the whole idea of, the disruption of the society as a whole, and thinking of ourselves as not just biological organisms, but psychological beings and social beings have been impacted by the epidemic. And I'm ready to push this, over now. And only to say that we have a long list of readings, which I think are absolutely fascinating for any of you. And Catherine, Dr. Doherty and I have a pile of papers here and copies we can make for anybody nearby who wants it. So Mark, are you ready?
I am ready.
Okay.
Okay. Thank you, Dr. Marotta, for a absolutely terrific and stimulating presentation. No, I have no disclosures. This was intended to be a somewhat dark humor slide, reflecting, I think, what all of our feelings have been and experience have been related to the pandemic and thinking back on it, although we're not completely out of the woods, of course. And the point of my talk overall, I think, is that to demonstrate basically that the virus, as Dr. Marotta has said, it's not only a vector for particular brain regions, but in our experience was and may be a vector for large hospital systems and psychiatric hospital systems in particular, that clearly caused a tremendous amount of disruption. And what I'm going to be talking about today is really our experience on an operational level, looking at New York Presbyterian behavioral health. So to bring us all back to the pandemic, the pandemic, of course, hit the East Coast in March of 2020, and New Rochelle, New York, turned out to be sort of ground zero for the pandemic in those days. And New York Presbyterian, Westchester Behavioral Health Center, just a few miles away from that location. New York Behavioral Health, just to level set a little bit, consists of Weill Cornell psychiatric inpatient unit with 32 beds, Columbia 24 beds, Westchester Behavioral Health in White Plains 230 beds, Gracie Square Hospital about 120 beds, Allen Hospital 50 beds, and Brooklyn Methodist 50 beds. So a huge behavioral health system totaling about 500 beds. So there was an enormous need, as people recall, for medical beds at the beginning of the pandemic. So how that affected us was that while Cornell campus basically lost 32 psychiatry beds, they were converted to medical beds. The Allen Pavilion beds were likewise closed, as was Brooklyn Methodist. So we lost a huge chunk of our available psychiatric beds. Fortunately, in the beginning of the pandemic, the EDs were relatively quiet, if you remember. I think people were reluctant to come to the hospital for their psychiatric needs because of general fear of infection. And April 3rd, 2020 was the day that the first COVID positive patient was admitted to our facility in White Plains. So looking back, what are the challenges? What were the challenges in terms of dealing with patients with COVID-19 in a psychiatric setting? Well, you know, they're quite obvious in terms of the physical plant. We're a locked community setting. That means that you know, people were constantly interacting with each other. They were sleeping in the same room in doubles. There was poor visualization into bedrooms. It's not permitted to have windows or vision panels, so you couldn't just keep the doors closed. Dining rooms are communal, group rooms, of course, communal. Nursing stations were small. There was no areas for donning and doffing of protective equipment. There's a paucity of sinks and sanitizers. Of course, no negative pressure rooms. In terms of the treatment challenges, how do you provide psychiatric care? You know, wearing PPE. Everybody, of course, was masked, and a lot has been written about the effects of that on interactions, let alone in psychiatric interactions where you really cannot see most of the face. The effect on the milieu, individual, group, family therapies were all going to be huge challenges for us. Staff training, looking at the beginning of the pandemic, was an enormous challenge. We are a psychiatric facility. We are not expert in infection control measures. And on top of that, of course, was layered the problem of people's emotional reactions to COVID and fears of infection. The patient population posed an enormous challenge. We decided in the beginning, of course, that we could only treat COVID patients with mild to moderate disease. Anything more than that, of course, would require a med-surg setting and sometimes ICU treatment. But in terms of the challenges of our patient population, patients with chronic psychiatric disorders, of course, were going to be very difficult to manage in an infection control environment. The patients who are depressed and concerned, we have concerns about isolation of those patients. If we had to isolate them as well, that was countertherapeutic. Cooperation among personality disorder patients, cognitive and functional limitations with autistic spectrum disorder patients, cognitive limitations for our geriatric patients, and of course the kids and adolescents, all of the above, created tremendous challenges. April 3rd, as I mentioned, we received our first COVID patient. As you can imagine, there was a great deal of anxiety around receiving that patient, but it quickly became commonplace for us to do so. And as you can see, as the months progressed, in April and May, the cumulative number of patients in our health system increased. And at its highest point, close to 20% of our patients were COVID positive in the beginning of the pandemic. Our initial steps in addressing the pandemic really involved organization. And the first thing we needed to do was to make sure that there was reciprocal education and training between our psychiatric staff and our infection prevention and control staff. We were a large academic facility, mostly based in New York City, and with a very rich and robust infectious disease division, but they knew really nothing about psychiatric care and the challenges that we faced in our environment that that I alluded to at the beginning of the talk. So the first step was really to acquaint them with our physical layouts, with our operational challenges, and so on and so forth. And conversely, our staff needed to be trained in infection control measures. Communication turned out to be the most important operational initiative. That it became clear from the very beginning that without really robust communication, we were going to be behind the 8 ball throughout the pandemic. So we developed a command center that was vertically integrated. We met 7 days a week. We looked at patient flow every day, our infection control measures, our protocols, our staffing, our supplies, and everything else you can imagine. And we need to do this across the service line. We had to standardize our practices across all of the psychiatric facilities in our service line. And we were also faced with having to, from the enterprise, that is New York Presbyterian, not just psychiatry, there was redeployment of psychiatric beds that I alluded to earlier, but also staff. Residents were pulled from our department to man emergency rooms, phone systems, and so on and so forth. It was all people on deck at that point. We had to develop medical protocols for screening and for managing patients. Patients who were of undetermined status, people who had COVID-like illness, but we weren't sure, patients who were positive, people who were exposed, staff and patients receiving CPAP, patients receiving ECT. And we had to come up with mitigation and contagion strategies across the board. We had to define terms. What did we mean by these things? And again, it became very important from a communication point of view to be explicit about what we meant by COVID-like illness. These are people who were symptomatic but had not yet been diagnosed. Obviously, confirmed case of COVID was obvious in terms of what that meant. We developed the term a person under investigation. It sounds like the FBI or something, but basically this is a symptomatic person who is being tested for COVID-19, but we didn't have the results yet. And we had to define what we meant by exposure. And that basically meant that you had to be with somebody who was COVID positive for over 10 minutes within 6 feet and generally unmasked or inadequately masked. I apologize for the complexity of this slide, but whoops, sorry about that. This does, in some ways, reflect the complexity of what we had to deal with. So we had referrals to the hospital that were clearly COVID negative because they were screened. They were admitted to the hospital, to our COVID negative units, and basically were involved in all of the usual infection control protocols. Some of these patients were persons under investigation, so that we didn't know necessarily the COVID status of those patients. We were waiting testing. I have more to say about that in a moment. And then we had patients who were asymptomatic referrals who did not know their COVID status. And if they were cooperative with room restriction, they were placed in a holding space in one of our general units. If they were asymptomatic and not cooperative, they were still referred to our general units, and we did the best we could in terms of maintaining isolation for those patients until we could get the COVID resolved. And if they were symptomatic but cooperative, then we would still put them on a negative unit, but with drop of precautions, awaiting their COVID negative results. If they were COVID negative, they were basically maintained on that unit. If they were COVID positive, then they went to our COVID positive unit. I'll say more about that in a bit. If a patient came in who was not cooperative with room restriction or testing or isolation, that patient was admitted to our COVID positive unit. And obviously, if the patient was COVID positive, they were sent there. These patients could eventually end up having to be sent out to the emergency room if they met certain criteria. In terms of our persons under investigation, if they were positive, they would go to our COVID positive unit. Otherwise, they would remain on the COVID negative units. We developed protocols for screening. So everybody who was admitted to the hospital was screened 48 to 72 hours prior to admission, unless they refused to be screened, in which case they were dealt with in the way that I just mentioned. In the beginning, we insisted on 72 hours. As the pandemic worsened, we went to 48 hours. And many of our patients came from emergency rooms that were essentially hotbeds for contagion, so that was a problem. We did initial evaluation, medical evaluation of the patients. Patients who were suspected COVID-19 were placed in a single room on droplet precautions until the result was obtained. We had clear protocols for vital signs, pulse oximetry for all types of our patients. And we had indications for medical assessment should they develop symptoms on the unit. And we had a retesting protocol as well for patients under investigation who remained symptomatic. Again, our medical evaluation for patients with COVID-19, we specified the frequency of monitoring. Our treatment was largely symptomatic. We did not really get into Paxlovid very much, which was really towards the end of the pandemic in any case. We were told by infection control that we could cohort 2 patients who were positive for COVID. We actually never ended up doing that. We developed criteria for discontinuing drop-in precautions for our COVID positive patients. I'm not going to belabor exactly what we did, but as you recall, the isolation recommendations were 14 days at the beginning. That went down to 9. It included 2 negative tests. That was later abandoned as well. We learned more about the disease. In terms of patients who would become very, very sick, and some of our patients did go from mild to moderate disease, we developed clear criteria for when we would transfer patients to an emergency room. So if their pulse ox went down below 93, obviously if they were having labored breathing, shortness of breath, other vital sign changes that were consistent with the deterioration in their illness, they were sent to the emergency department. We developed exposure protocols for our staff and for our patients, so that if there was an exposure on the unit, we had a very clear protocol for how we would monitor those patients. In many instances, we had to close units when there was exposure on the unit. The decision to do so was done on a case-by-case basis, and we were always informed by infection prevention and control as to how to do that, how best to do that. We always did tracing of the exposure so that we had a good sense as to whether or not we needed to close the unit or not. We would do testing of everybody on the unit. At times, there were a variety of things that we could do. Mainly, we were looking for compliance of the patient who may have been exposing others with mask wearing. That ended up being the major criterion for decisions about closing units. CPAP turned out to be a huge challenge for us. CPAP machines actually aerosolize expired breath so that the droplets that are produced are actually more likely to cause contagion and infection. So it's a very high risk circumstance that we felt that we could manage under certain circumstances and parameters. We did not feel that we could take somebody who we knew was COVID positive, who needed CPAP. That patient really needed to be in a negative pressure room, and we obviously did not have that facility. So we would not accept patients who required CPAP, who were known to be COVID positive. But as I've alluded to, there was lots of contagion on the units, and patients on CPAP could become COVID positive in the course. So we developed clear protocols around testing them on a weekly basis. In addition to that, we developed CPAP rooms on every unit. We got a waiver from the New York State Office of Mental Health to allow us to build vision panels in these rooms so you could actually see in without having to open the door. We put boxes in these rooms to conceal electrical cords, again, because of ligature concerns. The bedroom doors had to be closed during the use of CPAP, and for 60 minutes afterwards. Somebody had to go in. They had to go in full regalia, of course. As I mentioned, we had weekly COVID testing. Patients who were, there were a variety of other mitigation strategies that we used in addition to social distancing, minimizing the number of patients who were in the dining room together, cohorting patients in groups, maximizing time spent in rooms. We liberalized the use of mobile phones. We eliminated visitation early in the pandemic. And we introduced iPads universally for all of our patients so that we could continue to have groups. We can have contact with nursing staff, contact with family. Our adolescents and kids could continue school through the iPads. And we developed protocols to safely manage the iPads as well. In terms of ECT, we did not stop ECT during COVID. Patients who we knew had COVID-19 did not receive ECT again because of the aerosolization risk in that setting. Patients getting ECT who were COVID negative would be tested on a weekly basis, and we modified the ECT procedure. I'm not going to go through all of the details of that, except to say that as you can see, a lot of effort was made and time spent to make safe the process. In terms of preparing patients, we added a cleansing of the nostrils and the mouth, which was not part of the usual ECT procedure. We maintained the minimum number of people in the ECT suite, of course. PPE was extensive, N95s. We developed a system where there was minimal positive ventilatory pressure. Again, we did not know whether we would be potentially making patients worse by pushing virus deeper into their lungs with a strong pressure. In recovery, we avoided the use of nasal cannulas, again, because of potential for contagion, and relied on masks. We, as I alluded to earlier, developed a COVID-19 unit. This was our amenities program at the Westchester Division. And you can only imagine what the meeting was like when the director of nursing and I met with the staff at the beginning of the pandemic, letting them know that we were converting the unit from our amenities unit to our COVID unit. There was a deer in the headlights reaction initially, but to the staff's credit, they really rallied. And we developed an absolutely stellar service. There were 16 beds. Everybody was obviously in a single. There was a part of the unit that was physically, there was a wall built essentially with a door in it for the most uncooperative patients to minimize exposure. We had a dedicated donning and doffing room. We had extensive training of those staff in infection control. And it became the beta site essentially developing our iPad technology. And what happened was that an amazing esprit de corps developed among the staff, and it turned out to be an extraordinarily successful program. So just when you thought it was over, Omicron hit, and this was, as people recall, a more transmissible variant. So all of our protocols that were in place, we continued. However, we were finding that we were getting an inordinate number of unit closures. So each black arrow here represents a different unit closure. Now there are 12 units in the hospital. At any given point, we had several units closed. At its peak, we had 60% of our units closed to new admissions. And again, from a patient access and patient flow point of view, this was a disaster. So we developed yet another protocol where obviously COVID positive patients on admission went directly to the COVID unit. But what we did was we established several units that were considered admitting units and admitted all patients to those 2 units. Patients admitted to those units were in a 4-day quarantine. So in other words, they were negative on admission, and then we retested them 4 days later. And if they continued to be negative, then they continued on the unit or transferred actually to one of our other COVID negative units. And if not, they went to the COVID positive unit. But they were on droplet precautions and isolation for those 4 days. As you can see, many unit closures, but after we implemented that strategy, we thought that it was pretty successful. There were no unit closures after the time. And I'm approaching the end. I just wanted to remark that we're not only focusing on the psychiatric and medical aspects of what we were doing. We were also focusing on the ethical issues involved in treating psychiatric patients who may or may not have COVID-19. And the issue of to what extent do you coerce a patient to be tested, to be in isolation, to be secluded? These were issues that we grappled with and we struggled with. And I think fortunately, dealt with in humane and reasonable ways, and several of us wrote about it as well, and provided some recommendations from an ethical perspective in terms of managing the epidemic and the patients. We were not alone. Many of the things that I've alluded to, if you look at the literature from Norway up the road in New Haven, Dr. Lee, and in England, everybody from the perspective of inpatient psychiatric care is basically dealing with the pandemic in very similar ways. Even though there was no coordinated effort, people came to very similar conclusions and adopted similar strategies. What were the outcomes overall? Obviously, there were many negative outcomes. There were patient deaths associated with the pandemic, even in our hands. Several of our patients ended up being transferred and not surviving. Tragically, four staff members at Westchester perished as well as a result of the pandemic. There was staff attrition and burnout. People, as has been described in a variety of settings and industries, chose to retire, chose to not work in inpatient settings anymore. So all of those were challenges that we, in many ways, continue to address and continue to struggle with. But there were silver linings as well. Clearly, the pandemic forced us to accelerate technological changes, and the use of iPads in particular, continued and really has opened the door to providing group sessions across units, various kinds of educational material that did not exist prior to the pandemic. Communication with families. So this was a major win in terms of our experience. Clearly, we all became more comfortable with infection control measures and medical management issues, and I think that also was a positive outcome. In our setting, the COVID unit experience, that is to say, having a staff that wanted to run in the other direction, allowed us to create other programs in response to other contingencies. In particular, we, as most psychiatric hospitals have struggled with an increase in aggression in our patient population, and we were able to establish a psychiatric intensive care unit. Again, with the idea that staff may not want to work on such a unit, but I think the experience of COVID allowed us to develop that program more seamlessly. And in terms of the adolescent surge, we had to convert units, adult units, to adolescent units. Again, extremely disruptive, but I think the COVID experience allowed us to kind of wrap our minds around that. And again, this is there was a lot of academic productivity. People really thought about this and wrote about this, and what's marked in yellow is just our small group in terms of papers that came out of this. But Cornell, scores and scores of papers came out of it as people really wrapped their minds around it. So thank you, and we have 15 minutes for questions for Dr. Marotta and myself.
I just want to say, wow, those were two tremendous presentations. And thank you, Dr. Russ. Thank you, Dr. Marotta, for really brilliance, and an honor to get to listen and learn from both of you. I want to turn to Dr. Gerber first for initial responses, and then we'll turn to the chat. I don't know, Andrew, if you had a thought or question that you wanted to lead us off with.
My thought's just the same as yours, Jeff. I mean, I've never heard two such terrific presentations on COVID. It's obviously all this is very sobering, particularly what Rocky shared with us. But I think Mark sort of showed us that there's a way through this, and there's a lot more work to be done. So I'm going to leave it at that because I want to get to the questions. There's a lot of them here. And Jeff, I don't know if you have a question picked out you want to start with, or if you'd like me to.
Sure, I will start with the top with the anonymous attendee, which I know, Rocky, you started us off with, but what can be done to offset or reduce some of these scary long-term effects you predict? We can spend a few minutes with that. I know you kind of led us in that direction anyway.
Yeah, it's kind of hard because we don't really know where we're going. There's so much being done and so much great attempts, looking at huge data sets but also running studies. So something may turn out. I mean, when I asked my old friends, what do they think something bad is going to happen in terms of the virus coming back, they think that's a low probability. So I think we now are in the position of saying, well, what do we do going forward? And hopefully nothing happens. It's just being alert to it. But I'm really touched by this idea of the inflammatory responses, and that Fernandez Castaneda paper in Cell on that CCL11 protein, having that effect and rising with COVID infection. So I think that might be some things that are right in front of us, like exercise, fresh air, good food, an aspirin a day, it might be something like that, because the data that just came out in JAMA about the rates of abdominal cancers, again, being lower on aspirin. It may be something like that would be very, very helpful. And I think, exercising your brain and keeping going is very, very important. I mean, a lot of my friends talk about the importance of resilience. I think I should have used that word, but I think resilience in response to this is incredible. And we think back to my grandparents, right? They were resilient, they kept going. And even, there's this kind of, our job is to keep each other going and take care of each other no matter what happens. And I think we'll do fine. But it's going to be bobbing and weaving, a lot of bobbing and weaving.
Beautiful.
Yeah.
If I could just jump in with a slightly
Yes.
more specific question, Rocky, on this topic of treatment. So which comes from our audience. One is the use of stimulants for that sort of brain fatigue. Obviously, it's use of stimulants is a controversial thing in many ways. But do you think that's a helpful potential intervention?
Well, what hasn't helped that much with chronic fatigue, right? But that doesn't mean it won't help with this. Now, my bias is that a non-amphetamine-like stimulant might be helpful, because it would be more akin to something what happens in sleep disorders and sleep apnea. So I'm wondering whether or not Nuvigil, Provigil, would be the kinds of things to go, or maybe, something gentler, or maybe even going back to caffeine in low dose. I mean, everybody was running around Rome, and it would, every 3 hours they were taking another espresso doppio, and maybe that works. I mean, it might be right in front of us. How have people adjusted? I mean, my own long COVID has been, I think the caffeine works. That's all I've done. I can't drink anymore. Not that I was ever a drinker, but I get migraines now, which I never had before, which is described by a lot of people. So if I have more than half a glass of something, I get a migraine headache, which is very uncomfortable. If you've never, they really are. They're not pleasant. And a lot of people tell me that's part of what they're going through is the headaches. But I think the GI stuff, omeprazole, right? But you're gonna. I think it's like was my bias is to treat symptomatically. I don't think there's going to be a specific thing to do. You're going to have to take a really, really good history, like we were taught as kids. Think about it. What could we do at any given point that might make a difference, and then evaluate the effect. When it comes to the psych patients, I think it's really kind of tricky, because I'd love to have another thing with Howard and Sumer and some others and find other people doing. We've seen some tricky things. Troponins of thousands in a patient. The white cells dropping in patients that never had anything like that before. Transiently, it throws you for a loop. It really is a problem. At least with the people because we have to watch so carefully. I think we're going to be blindsided occasionally and have to really be alert to what might happen, really alert.
What about anti-inflammatory or immunomodulatory treatments, Rocky? Do you have thoughts about whether ready to suggest those? And if so, when during COVID would you give them?
Well, when I get to listen to conversations, I know studies are being done, and they're trying to figure out how to do it. All that's always tricky when you have right. You don't want to you immunosuppressants, anti-inflammatories can interfere with immune reaction, right? You've got to be in the exact range, and so that has to be worked out carefully. But that's why I think certain things are relatively safe, right? If the coagulation numbers are intact, then you can use aspirin or Motrin and try. You might pulse with steroids. I mean, Mark got that crazy after virus where you couldn't stop coughing for weeks. I think, given what I went through with the COVID, with the constant coughing, every time I get any cold now, I just cough and cough. But like Flonase actually helped stop that. So my guess it's inflammation, and if I had to, I could have pulsed prednisone and probably would be even faster, and maybe I'll have to test myself to see if it gets better. The real troubling thing with the post-COVID is that the sleep disturbance really interferes with your functioning. And so many people talk about that. They just don't get restful sleep. They have aches and pains that interfere, or they just not quite right, but in the other thing that strikes me as being important is if you could find a way to keep the subgranular cells of the hippocampus, functioning at a high level, that would be a general response, and I think, oxytocin might be a way of doing it if it was safe, if you could do the study. Also certain vitamins, methylfolate, probably, and B12. Anything that increases neuronal regenerative processes, right? And also myelin, because some of those inflammatory studies, the markers showed myelin decrease, and that might be the slowing, right? That might be the general effect of the chronic fatigue illness is demyelinization, critical demyelinization, little bits of it causing slowing. That's why I can't remember, there's certain, it's right there and it has to lose it. I have to run through things through my head, and I think it's just not firing the way it used to. It really feels like that, And they all describe that. People describe that sensation.
Well, let me just tell you that in the chat keeps on rolling, and I see now we're at 19 or 20 comments, many of which are just a testament to both of you about what an amazing presentation this was. Kenneth Burf says, what an amazing example of the meaning of physician love in the time of cholera. I have Dr. Ortiz Schwartz is out there. I think, Mark, I'll throw this question in your direction. She asked, do you have any thoughts about readiness for future pandemics?
Yeah, I do. I think that the first thing is making sure your head is screwed on tight. That basically take care of, take a deep breath, to channel house of God, take your own pulse, and make sure that as leaders and as staff taking care of others, that we're on firm ground. I think having an infrastructure that quickly can go into action with good communication. So any kind of incident command system that can deal with all emergencies, including pandemics, is I think critical. And I think one of the other messages to me was that we need to kind of re-medicalize psychiatry, particularly inpatient psychiatry. That we just have to become more educated, more familiar, more comfortable with managing a variety of medical issues. And I think those are things that we can do concretely to kind of prepare ourselves.
Great, thank you for that. Rocky Merriweather Brown is out there. and then asks, did any of the imaging studies show increased calcifications?
I don't remember seeing that. So I wouldn't be surprised if they did a scan that specifically there would have to be, right? Along any line of it really increased damage that would happen. And maybe it's embedded in one of the pathology papers and I don't remember, the reference to it. Yeah, I wasn't scanning for that because I thought that's a general response with, tissue death. You'll see, little bits of that along the blood vessels. So it might have been there and I missed it. So.
Mark, I wanted to follow up with your last comment about what we're learning from this and for the future. I mean, one of the tensions, it seems to me, is between the desire, very understandably, to say this is over, and for colleagues and for staff who come and say, well, we put COVID behind us, let's get back to normal. And yet at the same time, the realization that it seems fairly likely that we're going to have to at least face something like this in the future. And I wonder, from a leadership perspective, if you have thoughts about how do you create a balance between wanting to give everybody some sense of normalcy, but at the same time knowing that there are things awaiting us that we don't even know.
Yeah, well, I think this is a broader challenge in our field, that psychiatry, particularly in institutions and hospitals, is changing, and we've been saying for decades, patients are getting sicker, and they're getting sicker in a variety of ways. From a psychiatric perspective, I mean, clearly, we had data at New York Presbyterian showing, for example, the percent of involuntary admissions went from 30% to 43% over the course of a couple of years. So these are pretty, from my perspective, hard data that the patients who we need to treat are different than they were several decades ago. So part of it is sort of coming to terms and understanding from a leadership perspective with these realities, that we have to quote Rocky, we have to be more resilient, we have to be more flexible, we have to be more agile, and I think that applies to medical issues as well. So these are some of the lessons that I think we can learn from this experience that really has been clearly traumatic. I mean, there's no other word to use. I mean, we were all traumatized. We are traumatized by this experience, and so I think from a leadership point of view, I think to understand that the work has changed, the work is changing, and that's not that's not inherently a negative thing. It calls upon us to be more creative, more energetic, thinking in new ways, which I think can be extremely exciting, and is the nature of what we do, and we should embrace it, not run away. So that those are some initial thoughts.
Thank you.
Thank you. Well, we are at the 1 minute mark, so I think we will close here, and wanted to thank you again, Dr. Marotta and Dr. Russ and Dr. Gerber, for joining the panel up front today, and thank you to the over 200 people that have tuned in from around the country. It's been wonderful spending the time learning together from again, really outstanding leaders in a time that I think we're all reflecting upon now, that you're bringing us back to what's happened, and we're wondering together as well about what is to come and how prepared are we for that. So thank you, and thank you for concluding the Grand Rounds segment today, and we will look forward to welcoming everybody back in September. Thank you again. If you would like CEUs, CME, the link will appear in the chat, and we will also email that to you. Thanks, everyone. The ending is abrupt, so here it comes. Thanks again.
Thanks, everybody.